We're going to be talking about transitioning seniors and people with disabilities to Medi-Cal managed care. And I'm just going to do a little bit of just housekeeping real quick before we get started. This session will be recorded, and so please try to remember to reduce distractions and background noise. Send your calls to voicemail, etc. Please do not put your phone on hold, as we'll unfortunately all hear the music. And in the interim, we will probably start with placing all lines on mute, but would like to be able to unmute folks so that we can field questions after the speakers speak. If you have any logistic questions, you can use the chat box, which is at the bottom right-hand side of your page, and chat to the host. If you have a question to the speakers, you can chat to all. You'll see a little box that says send to, and you can either say choose all panelists, all attendees, or host and presenter. And we'd ask that your questions to the speakers go to all attendees so folks can see what questions you're posing. The other alternative is you've got a little hand icon right above your chat box, which you can click on, and it will allow you to raise your hand. And as long as the system has called you and you did not call a separate 800 number, then I will be able to recognize you to unmute you. Otherwise, if you called in separately, I cannot see a name with your identity in order to unmute you. But you can just chat in your question. So today's speakers, we're going to have 3 speakers today, are Bobbie Wunsch, Dr. Kelly Pfeiffer, and Dr. Bill Henning. And I'm going to do a quick little intro on each of them, and then I'm going to let Bobbie launch into her first set of slides. Bobbie Wunsch is a founder and partner in Pacific Health Consulting Group, which is a healthcare and management consultant. She's a healthcare and management consultant who specializes in working with safety net providers throughout California. She spent the last 40 years working within the public and community health sector in the delivery of women's reproductive health, primary care, and specialty health services. She provides consultation on strategic planning, program development, redesign for improved effectiveness and efficiency, and cooperative business ventures to community clinics, county health organizations, local Medicaid managed care organizations, which we're mostly talking about today, public hospitals, ambulatory care centers, and healthcare financing organizations. Since 1990, Bobbie has provided consultation to many California counties and local publicly operated health plans on expanding coverage to the uninsured. This has included consultation to many counties to expand coverage for uninsured children through the Children's Health Initiatives and to uninsured low-income adults, as well as the development and implementation of locally operated Medi-Cal managed care plans. She's currently consulting with a number of California's health foundations, including our own, and the state of California on the implementation of the DHCS 1115 waiver and healthcare reform for low-income uninsured individuals. And she's going to focus a little bit on the report that was written for our foundation talking about the transition of seniors and persons with disabilities into managed care. Dr. Kelly Pfeiffer is the Chief Medical Officer of the San Francisco Health Plan. SFHP is the local Medi-Cal managed care plan in San Francisco and is also the third-party administrator for the city's innovative healthcare access program called Healthy San Francisco. Under her leadership, SFHP launched many innovative projects aimed at improving access and care experiences, such as Strength in Numbers, which provides technical assistance and incentives for clinics working on panel management and team-based care. The Patient Experience Collaboratives, which have been providing technical assistance and training for advanced access and improved patient-provider communication. And the San Francisco Quality Culture Series, which is a leadership training program for clinics. Prior to joining SFHP in 2008, Dr. Pfeiffer was the medical director for access at Redwood Community Health Coalition, a network of clinics in Northern California, as well as the medical director for Petaluma Health Center. She trained in family medicine at Sutter Santa Rosa, received her MD from Medical College of Pennsylvania, and a BA in English from Oberlin College. Dr. William Henning is the Chief Medical Officer at the Inland Empire Health Plan and took that position in July of 2007. He oversees medical services, which include utilization, care management, wellness, quality management, behavioral health, and pharmacy. Since joining IEHP as medical director in September 2004, Dr. Henning has played a key role in a number of important projects, such as their behavioral health program and the expansion of their disability program. He has led the medical services team to numerous quality awards, including a CMS 5-star rating for pharmacy, one of only 5 in the nation, and scores of 100% on the CMS model of care, structure, and process, and multiple scores of 100% on the standards portion of NCQA accreditation. In addition, he leads an interdisciplinary team focusing on care and disease management to develop individualized care plans for IEHP members, which aim to improve coordination of care, access to preventive services, and transition of care across healthcare settings. Prior to his work at IEHP, Dr. Henning served 15 years as director and practicing physician of a prominent San Diego primary care group. And from 1994 to 95, he served as chief of staff and subsequently as a member of his local hospital governing board. Dr. Henning is currently president of a state professional society, the Osteopathic Physicians and Surgeons of California. And he earned his medical degree from Western University of Health Sciences in Pomona, California. He completed a 1-year internship at Pacific Hospital of Long Beach before embarking on a 2-year residency at Phoenix General Hospital in Arizona. And he holds a Bachelor's of Science degree from the University of California, Irvine. So what I'm going to do here is I'm going to pass the ball to Bobbie Wunsch. And Bobbie, you should have this in order to do this. But Bobbie, before you start, can I just ask Dr. Pfeiffer to speak up and see if we can hear her? Okay, so Bobbie, I'm going to go ahead and have you speak, and we will keep troubleshooting trying to get Dr. Pfeiffer onto audio with us. Okay? Bobbie, you set to go?
Yes,
okay.
All set. Hi, everyone. Thank you for joining today. I'm going to spend a few minutes highlighting the key themes of a report that we prepared with the support of the California Healthcare Foundation. The first look, the mandatory enrollment of Medi-Cal seniors and people with disabilities into managed care. So I'd like to just give you an overview of the study that we did and then dig right into some of the themes. As part of this study, we collected and analyzed both primary and secondary data from a number of sources that included an online survey with all of the health plans involved in the counties that transitioned their seniors and people with disabilities last year, with 98 provider, advocate, and community-based organizations who were involved in the process. And then we focused our study in 5 counties: Alameda, Fresno, Los Angeles, Riverside, and San Diego. And we did not assess or survey beneficiaries directly. That is going on in a separate study that the Department of Healthcare Services at the state is currently conducting. And the results of that will be available, I believe, early in 2013. So here are the themes to start with that we identified. I don't think any of you will be surprised by any of them. Many, many months, and some say many, many years, went into thinking about, discussing, arguing about, disagreeing about the transition of seniors and people with disabilities into Medi-Cal managed care. And before the 1115 waiver was approved in 2010, many of the challenges that happened during the transition process, I think we all believe, should have been anticipated and thought through more in depth. And you'll see some of the examples of those as we go through this presentation. Secondly, and quite importantly, with all the talk that had gone on for many years before the transition, there really were no pre-established benchmarks or targets to measure the effectiveness of the transition. So as we talk about the transition, one of the things that we didn't have was any measure to know if we were seeing too many requests for continuity of care, too few requests for continuity of care, too many requests to be exempt from managed care, too few. And so I think as we look ahead to programs like the dual eligibles, we've recommended to the department that they start thinking about, well, how are we going to measure the effectiveness of the transition across the state? Efforts to engage providers directly and beneficiaries were limited and in some cases problematic. And although you'll see that the health plans did a lot of work with many of their providers and a number of beneficiaries, just wasn't enough. And the state did almost nothing with the providers. And then there were constant, and many of you were probably involved in these issues, there were many, many concerns about the rules and the processes regarding the medical exemption requests, called the MERS, and continuity of care for those individuals moving from fee-for-service Medi-Cal into Medi-Cal managed care. The health plans were involved in a number of activities, and almost all of the health plans reported participating in many of these activities as they prepared on a very short time frame to transition the community members into their Medi-Cal managed care plans. The health plans experienced many different things, but the most, I think, important thing that they identified that was most effective in reaching providers were in-person meetings and informational sessions. And they, as you'll see throughout this presentation, really found that the high-touch interaction, both with providers and beneficiaries, were most effective in getting to talk about the issues. And the activities that they themselves, the health plans, rated as least effective were written materials. People are very busy, in this case the providers, very busy. The same issues will come up when we talk about the beneficiaries. These are the issues that the health plans identified as challenges in reaching providers, and there were a number of them. Again, none of them particularly surprising. We also asked the health plans what the obstacles were in reaching beneficiaries, and you can see here they're very similar to the ones with reaching providers. None of these should be a surprise to anyone. The health plans also, we also asked the providers themselves and the advocates what kind of activities they conducted to educate their staff, to work with beneficiaries that came into their offices or that came to them for advice and assistance. And these are the activities that the providers and the advocates and community-based organizations most frequently engaged in. The providers and the advocates had a similar experience to the health plans in identifying that the most effective way to reach beneficiaries was a high-touch, one-on-one encounters and engagement through one-on-one or in-person education and counseling, through dedicated information lines or telephonic support. And they found most effective working directly with the health plans. And
hi, Bobbie. I'm just
yes.
testing to see if you can hear me.
Yes. Kelly?
Great. Okay.
Oh, good. Now Dr. Kelly Pfeiffer is on the line. That's great. I'll just continue. And here are the challenges that the providers and the advocates identified, very similar to the challenges that the health plans identified in working with other members of their staff, other providers, as well as beneficiaries. So let's review what we found as the major findings of this report. As I mentioned earlier, one of the key things is that many of the challenges should have been anticipated. The population of seniors and people with disabilities, as you all know, is extremely diverse. There's not one disability or one medical condition that impacts most of the individuals in this population group. They have complex and multiple health conditions and in many cases difficult living situations. The timeline for planning and implementing the transition of seniors and people with disabilities once the waiver was approved was extraordinarily short. The waiver was approved in the 1st of November, and the transition began in May, just a few months later. We've learned from a literature search and talking to many stakeholders that high-touch outreach, navigation assistance, and really personalized attention correlated with increased positive choice rates of beneficiaries choosing to go into a specific Medi-Cal managed care plan. And because of the short timeline and because of the processes that the department put in place and that the health plans were putting in place because of the timeline, there wasn't as much high-touch engagement with individual providers and individual beneficiaries as anyone would have preferred. Efforts to engage providers and beneficiaries, as I mentioned, were limited. And they were limited because there had been plans when the program was launched to have the Department of Health Care Services provide the health plans with a lot of data about the beneficiaries, about the services that they were using. The data came late to the health plans. Some of it was inaccurate and difficult for the health plans to interpret. And so the hope that much of the care, the history of care for these individuals would be taken into account as beneficiaries were assigned primary care providers and their care coordination was begun, didn't happen. Much of the contact information for many of the beneficiaries was out of date, and so that limited the ability of the health plans to reach out directly and talk to the beneficiaries. While there was a lot of health plan staff training, and the health plans did work closely with their network providers, the one area that wasn't covered by much of the training were the mental health needs of this population. And as I mentioned earlier, there were many unclear policies, particularly related to the two issues that people were most concerned with, continuity of care and the medical exemption requests. It's been very difficult throughout this process to correlate all the time and effort and resources that local stakeholders, both the health plans, the individual providers, the community-based organizations and advocates, all the efforts they put into place to plan for this transition. And we had as I mentioned, very few benchmarks or targets to measure the effectiveness of the program. The only real number that was available was the choice rate, which in an early stage of a program like this is an imperfect measure of success. We know the choice rates over time increase, and we didn't have any other ways to measure the effectiveness of the program. As I mentioned, the medical exemption requests and the continuity of care issues constantly and still are being raised by advocates and by health plans. As the policies seem to change or the interpretation of the policies seem to change, it was difficult for the health plans to recruit some fee-for-service providers into their networks. So many seniors and people with disabilities requested continuity of care so they could continue for 1 year with their current provider, and many of those providers have declined to join the health plans. And so at the end of the year of the beneficiaries' participation in the program, they will have to choose new providers. So as we look ahead, and we have a lot to look ahead to because the implementation of the dual eligibles program follows quickly on the heels of the implementation of seniors and people with disabilities. Lots of things to think about. One clear issue that seemed to ring true was that we probably need a longer transition period before mandatory enrollment begins. All of the policies need to be clear, well understood, especially by the people who will be helping beneficiaries, the health plans, the advocates, the community-based organizations that beneficiaries turn to when they have questions. We'll need to improve and intensify outreach directly to providers and to beneficiaries over a longer period of time. And the data that the health plans will receive to help the health plans provide continuity of care and ongoing support to the beneficiaries will need to be accurate and available more in advance than has been available in the past. And then, as I mentioned earlier, it will be really important to begin to define how will we measure whether the transition has been effective in the first phase and in a later phase. Lots of opportunities for the health plans to think about how they can increase the personalized, in-person communication with beneficiaries, how they can develop population-specific strategies. How do we reach out to individuals with mental illness, to immigrant and refugee populations, and how can the health plan target high utilizers who may need more intensive care coordination, support, or case management. So here you see a number of issues that the health plans certainly have already started thinking about, and you'll hear from 2 health plans in just a minute, and have begun to be working on. So I think I'll stop there and transfer the ball. Who shall I transfer the ball to next?
Why don't you send it to me, Bobbie?
Okay.
And Kelly, I will drive the slides for you.
Sounds great. Thank you.
Okay, and I now have your slides up.
Okay, great. Well, I really appreciate the opportunity to join you, and thanks for the invitation. I'm speaking as a small local initiative health plan who didn't have any experience with complex populations in the past. We were started in 1997 as part of the first round of managed care that was only for family aid Medi-Cal. So ironically, the population that probably least benefited from managed care was the first in managed care, and we also grew Healthy Families, Healthy Kids, and took on our local access program as the administrator for Healthy San Francisco. Our model was initially fully delegated, so the medical groups we worked with were performing the utilization management, case management functions. So we really did very little of what you traditionally think of as health plan functions in terms of utilization management, case management, disease management. We were fully focused on quality, and we certainly have been great there. We've won the Gold Award for Medi-Cal 5 years in a row. We're very proud of our quality scores, but we are really in our infancy in understanding what's the best way to support complex populations and to achieve the triple aim in terms of improving outcomes, experience, and lowering costs. So if you go to slide 3, we as a health plan took on this enrollment of mandatory enrollment of SPDs as a great triple aim opportunity. This is a population who stands to benefit the most from managed care. In terms of improved experience, having the opportunity to call someone and get an answer in your own language within a few seconds, having the ability to really have that personal connection that health plans can build. We also think that people who are part of a coordinated system as opposed to a fragmented system are going to have better quality of care and better outcomes. And then, of course, the concept is if you are not seeing several different specialists in several different systems and you're not in the PCP and the specialists can closely collaborate, you're going to have less duplication, less handoff errors, and hopefully a lower cost. So we did take this on as this can be a patient-centered initiative, but it was very challenging. I think one of the first things we encountered was this real tension between the role of healthcare reform being focused on the patient-centered approach and the need to do cost control, because even though we hope that in the end the people with disabilities would see the health plan as their ally and as an advocate and as a helping hand, the very first face they had from us was, no, you can't get the brand name medications that you got through fee-for-service Medi-Cal because we don't get the rebates fee-for-service Medi-Cal guide. And no, you can't see 5 different specialists in different areas, or if you do with continuity of care, you can only get the office visits and not the lab. So the first face they got from us was no, 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 and I think it was very frustrating for some of the folks. I mean, it was just ironic. We've had this one member who's taken me to the 3rd state fair hearing and is always saying he's going to take me to criminal court because I'm clearly making a lot of money from the state on denying him all his care. And the truth is our health plan, like many other health plans, spent more than we received in this first year. And we knew that would probably happen, that during this transitional year it was going to be very hard to manage the care of this population with the limited rates that we got from the state. And this is hard for patients to understand that, since all they get is that they're not getting what they used to get. On slide 4, we also know that we do believe there's a great future in managed care and to help solving the Medi-Cal problem, and certainly the state feels that way. We, looking at all the different services that the state has talked about putting into managed care, we started with seniors and persons with disabilities, but there's now the counties who are going into long-term care services and the duals, and we're going to be facing that. And even the conversation of integrating mental health. Is that change is happening so fast, and I will echo what Bobbie said in the past, that we think that managed care can be the solution, but it's just the pace of change was so fast that it made it a very challenging year for us, and I think a challenging year for the seniors and people with disabilities as well. So if you go to slide 5, we put a lot of thought into how do you safely lower cost in a population that's very complex without impacting outcomes or patient-centeredness. And of course, we know the state's main reason for moving this population to managed care is to control costs, but you have to do it in a triple aim way. So when you think about what tools do health plans have to lower costs, the first is lowering provider payments, but that's clearly off the table. California is being number 47 in Medicaid payments nationwide. We didn't have that tool of lowering provider payments, so we had to look at other ways to try and make the have this population be affordable within the tools we have, which are formulary, narrow network, utilization management, and patient-centered approach. And so I went on a roadshow and did similar presentations with a lot of providers, trying to get the providers on board with these are the only ways that we can take care of this population affordably, and then hopefully have a margin that we can invest back into the provider network to do transformation that we want to do in the delivery system. And our health plan's done a lot of work with trying to improve access and improve experience and improve quality. And the message I was going out to providers with is we can only do that if we have a reserve at the end of the year. And unlike commercial plans, we don't have to pay shareholders. If we have reserve, it gets invested back. So if you look on slide 6, this is a slide I showed with a lot of providers, that we got about $500 a month to take care of the entire care of a person with disability, including their hospital and pharmacy and everything. And so, but we also were trying to be patient-centered. So the very first approach we took was, let's give people 3 months of transition meds. So if they are on a bunch of brand name that they got from the state, to give them time to get in with their doctor and be able to switch the meds over. We gave them 3 months, and that was projected to cost us over $4 million, and so we had to stop that pretty quickly. And several of my peer health plans did that same thing of giving transitions, realizing it was unaffordable and that they were hemorrhaging money. Pharmacy cost and hospital days were our 2 big drivers of high costs in this last year. So we specifically focused on OxyContin. We were spending $5 per member per month on OxyContin alone. Out of a total pharmacy cost of $154, $5 of those dollars was only for one drug, OxyContin. And we've been able to get that down to $1.88 just with outreach to providers and helping them understand the cost of care. That OxyContin can cost thousands and thousands per month. If we get $6,000 a year to take care of someone, we spend $6,000 on OxyContin alone in 1 month. You can see that doesn't work. As you know, with protease inhibitors, that's been a big hit. A lot of these folks are getting Hep C treatment, and that's been one of the big cost drivers. And then also been doing a lot of education with providers about generics versus brand names, because the doctors, as you know, we're very cost blind. We have no idea that you can spend 5 times as much on brand names as you can with generics. And as you can see there, little on the slide 6, you know, the total amount that you'd spend just on Lipitor, Lexapro, and Prilosec, which are very commonly prescribed, would blow through our whole budget for someone for a year. So going to the next slide, the other way that we worked on trying to make this transition affordable is using this concept of a narrow or an integrated network, and to try and bring people into a system where they would have a clinic and a hospital that were part of one system and they got all the care within that. And that was really challenging because the continuity of care piece that Bobbie mentioned, it seems very appealing and it seems logical. You've had a relationship with someone, but it was very challenging in practice because it meant that people were going to one PCP outside of the network, and they that PCP or that specialist wasn't communicating with the other physicians in there. That labs would be in one place and not be able to get the results. So the continuity of care policy ended up being very, very challenging in practice, and in the end, I don't think it was very helpful. We really tried to limit that continuity of care and get people in medical group because they were going to have to get there eventually, and that way all of their care could be done in a way that really fostered co-management and coordination. Many of you know that in San Francisco we have this concept of e-referral, or this program e-referral, that allows specialists and PCPs to communicate very easily and co-manage patients, and that can really decrease duplication of services and handoff errors, and potentially avoid unnecessary or harmful utilization. A good friend of mine had a stroke because she had an MRI that she didn't need, which led to a brain biopsy, which she didn't need, which led to a complication, all for chasing down an incidental finding. So I'm really to teach my staff about this concept that more care sometimes can be harmful, and trying to support providers in having those hard conversations with patients, which can be difficult because a lot of providers prefer to use the health plan as the bad guy. And so going to slide 8, this was another slide that I used on my roadshow with providers, and I used in training our staff to try and help people understand is not just about saving money. It's really about trying to have evidence-based care and to try and avoid the bad outcomes, like my friend who had the stroke. And why do you need obviously, busy physicians don't always practice on the evidence, and it decreases the 2 types of variation that we saw clearly in the Dartmouth Atlas studies, where demand-based variation of reason for the prior authorization, the member wants an MRI, or and helping the provider be able to have those conversations. I'd love to give you this brand name, but your insurance won't let me. And also, as we're in a city with a tertiary care facility, and our specialist to PCP ratio is quite lopsided, so of course it also decreases the supply-based variation you see in the Dartmouth Atlas, where the number of ophthalmologists in town determine the criteria for cataract surgery, and the more ophthalmologists there were, the more likely someone is to say, well, you may just have a little blurry vision, but cataract will get bad anyway, so let's just take it out, and we do see some of that. So the last thing I'll say about how we're trying to control costs in this population is this concept of patient-centeredness, even in the department. And so as opposed to being a health plan where the main contact they had with us was a denial stamp of no, we really tried to close the loop with people and call patients and say, this is why we're denying this out-of-network specialist, this is how we want to bring you back in. We would really work hard to get people plugged into the PCP and specialties within the medical group and add that personal touch. And then if you go to the next slide, and I think there is some good data out there that a patient-centered approach can, in the end, lower costs, but when patients are well-informed, when they fully understand the consequences of their choices, there's a body of evidence that suggests that patients prefer the least intensive alternative, even if they're not directly at risk. And so I pulled that off of a recent Health Affairs, well, not so recent Health Affairs article about looking at variation in care. So this is, again, one of the teaching tools that I give with providers to try and have the health plan not be the black hat of denial, but that we're all in it together to try and achieve the triple aim. So in my last couple of slides, I want to talk about, going to slide 11, I think the really naughty piece about how do you take a population with a lot of mental illness comorbidities, a lot of substance use comorbidities, a lot of chronic pain, and transient housing or unstable housing. how do you work with that population and do really effective care management. Those of you know Kate Lorig, she's quite fierce. One time I heard her say, you know, I have 6 medical conditions and I'm not a case and I don't want to be managed. So we've actually not used that term case management, using the word care support to try and define our role as supporting patients in a patient-centered way to try and help them get the services they need. And so my governing board said to me, hey Kelly, figure this out. Your hospital days are too high. How are you going to make a difference? And I did some research and talked to other people in other health plans and looked for best practices, and I found that you can get a great body of data saying what to do with elderly people with CHF or COPD, but for people who have this triple threat of homelessness, mental illness, and substance use, we're all trying to figure out how to best support that population. So Tom Bodenheimer, many of you know, is very widely published, so we asked him to do some research nationally on what works best, and we're going to launch a series of pilots, and we're going to try and figure out what works. So if you look on slide 12, these are all the different ways that we're trying to figure out how to best manage a complex population in a patient-centered way to try and lower inappropriate utilization and improve outcomes. So the first one, we are piloting a care coordination fee where we're paying clinics and medical groups a $5 PMPM for every senior and person with disabilities that's enrolled with them to do care coordination case management, and we're trying to track that to see if delegating that function and paying clinics who traditionally haven't had that infrastructure can help. And then we also provide technical assistance to clinics and are working with Tom Bodenheimer and his team to train clinics how to do better care management. We also have a pay-for-performance program that's trying to incentivize lowering hospital days and implementing care transitions programs. We're convening a advisory group of experts in the community to try and improve pain management. We're providing technical assistance to clinics to try and implement best practices and protocols and doing some provider education. We had a big CME that we sponsored to help providers do more rational pain management. We completely redesigned our care support department to try and, again, figure out who are the people who need the most support and then how to reach out to them in a better way, getting them outside the 4 walls of the health plan, off the phone, and meeting people in person. We're implementing a care transitions plan with the Coleman model with a local hospital, and we're also considering hiring community-based care managers who just full-time out in the community, reaching people where they are. So that's the summary. I've got my contact information here, and please do contact me if I can help in any way. This has really been a learning process, and we're a learning organization. So thanks, and I'll turn it back over to you, Sophia.
Great, thank you. Bill, do you feel more comfortable with me advancing the slides, or would you like to advance your own?
Can you hear me okay?
Yes, we hear you just loud and clear.
Okay, I will try, and if I have a problem, I'll let you know.
Okay, I'm going to pass you something called that blue and green ball, and you should get a little alert, and under you'll see a little box that says 0, 1 and some arrows that go front and back, and those are the ways you click on those to advance or reverse. Do you see them?
Very good, yep.
You got it.
All right, so I am Bill Henning. I am, as said, the Chief Medical Officer at IEHP. IEHP is the local initiative health plan, public health plan for Riverside and San Bernardino counties. What's interesting in listening to Kelly talking, Kelly and I know each other quite well. We work together a lot. We're a different look. They're a tight region in San Francisco. We're a huge, wide open territory, and where they have a nicely integrated network, we have a more wide open network of providers. But even with very different looks, our findings are very much the same, and our strategic planning looks very much the same. I'm going to focus a little more on some of the specific lessons we learned in the roll-in of the SPDs. We actually had previous experience with the SPD population because we've had very tight programs for the disabled advocacy community prior to the mandatory roll-in. We had about 20,000 SPDs that were coming to us voluntarily, so we had good experience and good data in that population. We gained about another 40,000 in the mandatory roll-in for a total of right around 60,000. So the SPDs are currently about 10% of our overall population of 600,000 members. Most of those, the vast majority of the Medicaid population, including the SPDs, but we also have a dual program, and we're the highest enrollers of healthy families in the area right now. So the lessons learned are not just great lessons learned for the state and future projects, but Inland Empire, Riverside, and San Bernardino are 2 of the counties out of the 8 counties that will be enrolling duals in the duals demonstration, now called the CCI, starting next June. And it turns out that when we look at our data, the duals are very much like the SPDs. They're just farther along that continuum of disease burden. And so the lessons we learned in the SPDs very applicable to the changes we need to make to get ready for the duals coming in. It turns out that about 18% of our SPDs convert to dual status on any given year. And so the SPDs can be thought of as almost as a placeholder in the continuum of moving towards a dual coverage type thing. If you look at the diseases, the graphs look very, very similar. This first slide, number 2 here, probably one of the more important lessons I can give, and I can't say this loud enough or frequently enough. Almost, and Kelly could attest, or any medical director or CMO can attest, we have vendors coming to us on a daily basis saying, let us help you do your case management. And our population is not a typical commercial or MA case management model. The disease burden and the needs for our population is very, very different from what I've seen in a commercial model. So we looked at outsourcing case management, we looked at outsourcing complex, and it just doesn't work. You can't do that because you need intense local knowledge. And in fact, the needs of our membership are, the vast majority, 90+%, are care coordination. They are people having a difficult time functioning in a very complex medical system. They need help with transportation, making appointments. You know, you're talking about an elderly person in a wheelchair living on a 2nd floor of an apartment with no food in the fridge and no great access to their primary care physician, and certainly no transportation to that primary care physician, who needs to see a neurologist who's 60 miles away. That's not typical case management. That's knowing your network, knowing your geography, knowing the players in the system, and helping them very intimately coordinate their care. So it's not congestive heart failure. And most likely, when you look at the statistics, the disease burden in this population is largely comorbidity between behavioral health and some type of complex medical issue. 50% of the SPDs who rolled into us had some behavioral health diagnosis. Now, only 18% of those were a serious mental health issue like schizophrenia or bipolar. Most of them are chronic pain issues. But people who have chronic pain are completely focused on their chronic pain issue and their medication, and they're not so concerned about their hypertension, cholesterol, or maybe diabetes issues. So until you can work with them on their major focus and build a relationship with them through your care management department, they're not going to really listen to you too much about your classic disease management programs. So one of the things we had already started was a unit we call a TNT, a Triage Nurse Team. This is a new unit made of coordinators and nurses that really back up our member services or customer service unit in our program. Pretty much everybody enters through a customer service phone call door, but right away the member services team was getting overwhelmed with a majority of these fairly complex issues and difficult patients, and needed someone to hand it off to, so we significantly expanded our TNT team as a backup. So the phone call, the workflow, basically goes from member services to TNT. If TNT can handle it quickly, and quickly is within half a day, great. If not, then they're going to largely hand it off to classic case management, complex case management, disease management, or find the right venue to handle the problem for the patient. Again, the issues that are coming in, largely they're authorization issues or continuity of care issues. There was a lot of continuity of care issue when people rolled in. They were seeing providers frequently outside of our counties that we did not have in our network. So we were having to reach out with letters of agreement for a lot of new providers to try and keep people in care in their current care. There was a lot of medication issues, and they didn't fit into classic care management kind of systems. Now, there were so many people with very specific special care needs that didn't fit into any classic that we considered opening up a special needs pod. And the pod would be highly specialized people that were just problem solvers. For example, we had a lady who only spoke Vietnamese who would routinely show up here in our reception room in her wheelchair and not understand what she was supposed to do to go see her doctor or her specialist or how to get her medications. And this was happening 2 or 3 times a week. well, that person doesn't really fit into classic complex case management and didn't really have a home in our program the way it was built that could take care of her. So we were going to build this silo for her. And then I realized, oh my gosh, I'm going to build another silo. And what we were doing is moving down a path towards building these specialty programs that fit us and specialized our team, but they didn't really wrap around the patient very well, and they weren't member-centric. So we've now, just this week, finally kicked off a complete reorganization of our care management team to be completely member-centric. Every member will essentially be assigned to a person at IEHP, and that person will be a 3-person team that consists of an RN, LVN, and a coordinator. But everything that that person needs, whether it's disease management, access to care, transportation, interface with their medical group or their primary care for the provider, happens in that small unit instead of being farmed out to a team. So more to be talked about later. Really what you're doing is case-by-case problem solving. There was no overarching policy that could say, well, we're going to do this change and it's going to fit this population. Every case was different. Got a 25-year-old autistic that couldn't go into a doctor's office because he would tear the office up out of anxiety when he came in. This guy's 250 pounds. Nobody could control him. So his primary care doctor was going out to the car, taking a look at him, and giving him his Haldol to keep him controlled. Well, that doctor said, I'm not going to be in managed care. Find someone else to take care of this gentleman. And so good luck, right, finding somebody else to take care of him. So it was that kind of case-by-case solving every day. Every day these cases are rolling in the door for us. And as I said, many of the cases were comorbid behavioral health and medical diagnosis, but the problem there is that behavioral health is a carve-out in our model. So county mental health has risk for Medi-Cal mental health. And there, as you know, has been difficulty coordinating care between mental health and medical health. Since we had never really had risk for mental health, we sort of had been looking the other way and said, it's not ours, we'll take care of medical. But the reality is, even if you're not getting the dollars for it, if you're not managing the mental health, then you're not managing the medical health either. And we really needed to come up with a system for managing both, so we ended up bringing behavioral health in-house. We needed to do it anyway for our Medi-Medi patients, and we simply expanded the unit to have capacity to help do coordination of care. Our behavioral health department has done some very innovative things about solving the problem of coordinating communication between the mental health provider and the PCP. And that's working quite well. We've got good coordination going on it now. But, you know, as long as you've got a split financial risk, it always creates holes for people to fall through the cracks. Pharmacy issues are big for us. Like Kelly was saying, we allowed 8 months of grandfathering of their current pharmaceuticals instead of forcing them into our formulary. In essence, all you do is kick the can down the road 8 months because it's still going to come due. Our formulary doesn't line up real well with the state's Medi-Cal formulary. We are almost an exclusive generic formulary with very little rebate influence on our formulary decisions. And so people were coming in with a lot of trade medications like the OxyContin, like the Nexiums, things like that they'd gotten in their fee-for-service. And we knew it would really clog us up if we tried to convert them all to formulary right away. So going okay, you know, we're now well into that 8-month grandfathering phase where we're trying to convert people over. And it's going fair, but it's still creating some havoc. The largest havoc in the system were the narcotic users. These people get very anxious when they run out of their medication, and it turns out that in fee-for-service, something we didn't know, was that they'd get a prescription for a 30-day supply. They'd go through their 30-day supply in 2 weeks, and basically all the pharmacy had to do was apply it to the state, and it was an automatic refill at the state level to refill these medications. So when they came in our system and ran out of their medication 2 weeks early, it would click out into a prior auth queue, and we had to then go and approve it for a prior auth, which slowed down. And if you wait more than 6 hours, they start calling member services. And so you get this snowball effect where they were calling constantly, member services trying to get into the pharmacy who was trying to do their work instead of answering phone calls. And it's not been real pretty. So we're actually, the solution there is we're setting up a pharmacy call center where the calls can come directly into pharmacy rather than going through the network. It turns out that in the SPD population, which I said before is 10% of our overall membership, they are responsible for 40% of all pharmacy exception requests for the organization at this point. as Kelly said, our costs are significantly more than the actuarials that were supplied to us by the state at the start. I think we all said, this isn't going to work, you're not giving us enough revenue. And they said, no, we've crunched these numbers really well, it's good. Well, I think she said it was 104% or 102%. We're 110% of our predicted costs, so we're 110% overrun on our revenue. And when you look into detail, I'm going to show you, but it's in hospital inpatient, specialist utilization, and pharmacy claims that largely our SPD folks are overutilizing or utilizing beyond what the state thought they would utilize. And on this page, page 7, it sort of shows you a little detail. So as I said, we had good detail on 20,000 previously voluntary SPDs, and then looking at the 40,000 new SPDs, you can compare the two, and you see that for inpatient costs, and this was, I don't have the date, June of 12. There was a 26% increase in inpatient costs from existing to new, 4% increase in specialist costs, and 11% increase in pharmacy costs. And that was in June. If you look at the slope of the curve on the inpatient utilization for SPD, it has not yet leveled out. It's going on at about a 45% angle and has gone off the page as we continue through my August and now September information, and I've yet to see that plateau. So I'm very concerned about the hospital utilization and the sort of lag effect we've seen in the 12-month roll-in in our population. We are continuing to see significant overutilization of very specific durable medical equipment. We are looking at and denying requests for either replacement or repairs of about 4 power wheelchairs a week. It turns out in the fee-for-service system, it was very easy to get a power wheelchair. You basically just had to go to your doctor, have him sign the form, convince him that you needed it to go to Walmart, and you got a power chair for about $15,000 from the state of California. But the state of California's criteria for who should be getting power chairs is significantly different. And when you apply the actual criteria, an awful lot of people got power wheelchairs that should have never got them. And this is not unique to power chairs. There's an awful lot of examples out there of how easy it was to kind of get around the TAR system for the state, and how really the savings that are anticipated in managed Medi-Cal are really about oversight and correct utilization and stewardship of public funds. So we don't want to be mean, we want to make sure people get what they need, but there's an awful lot of people that got power chairs that probably didn't need to have a power chair. This slide just talks about grievances. In the early 6 months, we were pretty, it was nice. We weren't seeing a big increase. And in fact, I'd say in many ways, we didn't see the disasters we thought we were going to see in the first 6 months. It took a while for them to hit the system. It took a while for the hemophiliacs to hit. CCS kids, I don't think was mentioned, but CCS kids for some reason got held back and all got enrolled in May. So why they didn't get enrolled during the course of the 12 months, we're not quite sure. So that really impacted our utilization. It didn't look as bad when you took the sickest kids and suddenly brought them all in 1 month. All of a sudden your utilization really went up. The same thing with grievance. There was a lag early on, but now our grievances are way up. Our total grievance volume has doubled in the last 3 months. The grievance rate for the SPD population is 5 times. It took them a while to figure out kind of how the grievance system works, and now they grieve about a lot of things, pretty much everything. That is the end of what I've got. I will turn it back over to Sophia at this point and be ready for questions if you have them.
Thanks, Bill. And Val, if you could drag that little ball in front of my name, that would be helpful. I do have one quick question for Bill, as others are encouraged to put in their questions in the chat box. But when you mentioned that you are doing a much better job now in coordinating the mental health and primary care side of the house, can you give a little bit more of an example of how you're doing that successfully?
So there's different coordination of care depending on if you're working with your own independent behavioral health network or if you're working with county mental health and their network and their system of care. In this population, of course, we're working with county mental health, and that's more challenging. In our behavioral health network, the way the electronic and what we're rolling out now with county mental health, our department, Dr. Curry, who set this up, set up an electronic communication system from the very onset. It was part of their original contract that they had to participate in the system to be a provider for us. And so at the time of their initial evaluation, they fill out an electronic evaluation form that talks about history, diagnosis, medications, and they submit that electronically with their claim. They can't get their claim paid unless they send that evaluation. We collect those and then distribute those electronically to the primary care physician. We try to roll that same system out at County Mental Health, and it's very difficult for them to move quick or adapt to that system. They want to do it. They're trying to do it. One of the things we're in the process of doing right now is we're hiring social workers that will be embedded in the county mental health departments of the two counties. We work with two counties. And so they'll actually live there and be part of their system and have access to both of our systems. We piloted this with Regional Center years ago, where we hired social workers that were embedded in their system so that patients didn't fall through the cracks anymore. They could be seen in both systems, and then care could be coordinated between the systems. So the county mental health are soon to be started on the electronic system. They're trying, or we're in the early stages, and we think they'll be successful in doing that as well.
Thanks. And a quick question for you, Kelly. Are you still on?
Yes, I'm here.
Which is, can you talk a little bit more about how you trained your staff to be patient-centered? Because it sounds like some of these difficult conversations about why they wouldn't get access to certain things could be quite difficult.
Well, I think that some of it, we had some overlap and sent some staff to a care management plus training that was done by Oregon Health Sciences University, which really is motivational interviewing, so just to try and orient them to a different way to talk to patients. I think a lot of it is honestly hands-on management. It's communicating vision in a consistent way, then having managers model the behavior, and then having and inpatient rounds with the associate medical director and I, where we would try and strategize and come from that patient-centered approach. So I don't think I have a magic bullet there, but it's really more just trying to change their perspective and change their attitude, and then set up policies that require high-risk people to get personal phone calls or personal redirection, and involving the PCP a lot more frequently.
Great. A quick question for Bill. I am going to keep us on a couple more minutes in case folks need to hang up. That's fine, but just so you're aware. This question is to Dr. Henning, which is, what is the enrollee to special team ratio? So you mentioned the special teams that you've put together.
You know, and this is a common question across plans, and I would avoid answering it just because what we've learned when we really study these ratios is that you can't make comparisons because every plan is different, and so your model is different. We, for example, are a hybrid plan. We've got a third of our membership coming to us through directly contracted providers, and 2/3 coming to us from subcontracted medical groups and IPAs. Kelly's plan's very different than that in their contracting and networking. And so our case management technically is delegated to the medical group, which means the case management should be living in their department, and yet we're doing oversight and coordination of care along with them, other than the third that comes to us directly. So it's really hard to talk about ratios because it's not homogeneous across programs. It's not even homogeneous across us. And every unit would have a different ratio. We currently have, so our TNT plan, for example, for a plan for 600,000 members has 12 people in it. It's 5 nurses and 7 coordinators right now. But that's just TNT. Sitting behind them, you've got complex case management nurses, which are 6. And you know, our enrollment in case complex is kind of low because of the way we've set it up. We really believe everybody gets case management, but whether we do it in-house or we delegate it out to the medical group really changes the ratios you look at.
Great. So I'm going to have one last question that I'm going to pose to both of you, and then we will end, which is, the use of generic meds has led to concerns from physicians and consumers regarding compatibility, efficacy, and efficacy of these lower-cost drugs. How are you managing this issue?
Hey, I'll start, Kelly.
Partnership Health Plans Associate Medical Director put together a couple-page fact sheet where he looked at all the literature, comparing generics and brand names, and we've spread that throughout our network, and I can send it to you, Sophia, if people want it. But I thought it was very helpful to look at, because it, for example, lists the 2,000, he says that the FDA has looked at 2,000 different studies that shows only a 3.5% difference in absorption between generics and brand names. It also looks at some studies that look at the seizure meds, because those are often quoted as the very dangerous ones that take people off brand names. That also looks more like a myth than a fact. But there's a lot of studies backing this up, and I'll send you that document because I found it very helpful.
Great, and I can post it with the slides when we post the recording along with the slides right after. And Bill, did you want to add anything there?
Yeah, I love this question because it's very frequently asked, and it's a very good question. But if you go to the science, go to the evidence is very clear. By and large, and Kelly's completely right that there's very few medications identified where there's justification for brand over generic, and those we allow. So wherever science says there may not be full compatibility, we will allow that, but it's probably 5 medications where that applies. The vast majority, your body doesn't know the name on the chemical when you put it in your mouth, and the chemical is the chemical. Your body responds to the chemical. Delivery systems and chemicals are important, but by and large the generics are using the same delivery system. So we have been oversold by the pharmaceutical industry that we should be using brand name medications when in fact there is no evidence to support that. Nexium doesn't work any better than Prilosec. It's the same chemical. Why would your body care?
And the generics are often repackaged and sold, and it's the exact same pill a lot of times once something comes off patent. And again, I would just echo that providers do get a lot of marketing and get confused, and the science just isn't there.
So what's important here is that, really this is happening, these decisions are happening at the Pharmacy and Therapeutics Committee level, your PNT committee. You want to be looking at what the PNT does and how they make their decisions. I can stand behind our decision making. It is very evidence-based. Every medication is looked at for literature to make sure that this is the best medication, the best composition, and the most effective price. But the first choice is made on efficacy, and then the next is if we have two different efficacies in generics, which one's the lower price and the more convenient. So it's very scientific.
Great. Thank you, all 3 of you, Bobbie, Bill, and Kelly, for your wonderful presentation today. Many of you can see where the recording of this, along with the slides, will be posted. And just a reminder that our next webinar will be on Wednesday, November 28th, I believe. I hope that's right. But you will get a notice from us if you're on our email list. And we look forward to seeing you and hearing you all in a month. Take care.
Thank you.
Thank you. Bye-bye.